Welcome back to Pharmacology. In this short block, we'll introduce a few concepts regarding changes in pharmacotherapy in the 21st century, particularly looking at what has evolved over the last couple of decades that are looking toward the future of pharmacotherapy. Pretty routinely now, we have a number of proteins that are generated by recombinant human engineering technology, DNA technology, to replicate either the identical or very similar protein found in humans. And this is true for a lot of pharmacotherapy, particularly in endocrine and hematology oncology. Specifically, what we'll use are the insulins in treatment of diabetes are engineered this way. Erythropoietin used to manage anemias, specifically anemias associated with renal failure, sometimes other conditions as well. And the colony-stimulating factors for treating or managing neutropenias in patients who have received chemotherapy that are bone marrow suppressing. There are a number of other proteins that are also used in pharmacotherapy. These include immunoglobulins, albumin, a number of vaccines are protein derivatives or proteins themselves, and each of these involve more intense manufacturing processes than were available 3 or 4 decades ago. The proteins typically we use in pharmacotherapy are not absorbed orally. They're mostly unstable to gastric acid. They're also fairly large molecular weight that would also render them, even if they were not broken down by gastric acid, would still probably be too large to be absorbed well by oral route. And so for the most part, these are administered parenterally. Typically, either intravenously or subcutaneously is the most common route of administration for many of these proteins. The proteins also have very specific storage conditions. Some are formulated in such a way to be stable at room temperature for a month or so, and that's true, for example, for most insulins, that while we refrigerate them, once they're taken out of the refrigerator, most insulins are stable chemically for up to 28 days, a couple of formulations actually up to 42 days. But for the most part, most proteins that are used in pharmacotherapy have to be at least refrigerated. Some actually need to be kept frozen, and when they are thawed, they have to be used almost immediately as soon as they're thawed. So proteins are fairly unstable chemical compounds compared to other medicines, and as such, their storage conditions can be quite precise. Monoclonal antibodies represent a major change in the management of a number of conditions. Specifically, in the last 20 years, we've seen monoclonal antibodies directed against particular inflammatory markers. The one we think of most often, I think of most often, is tumor necrosis factor, which is involved in the pathophysiology of Crohn's disease, of ulcerative colitis, and of rheumatoid arthritis. And so these monoclonal antibodies directed against tumor necrosis factor have been quite revolutionary in allowing many folks with Crohn's, ulcerative colitis, or rheumatoid arthritis to actually be put into remission. And that's pretty revolutionary. Before those agents were available, our techniques or processes were less precise. In the last decade or so, there have been a great number of monoclonal antibodies directed against certain protein markers and certain types of cancer cells. And they're very specific for that cancer cell and not for us, and render these agents much more effective and less toxic than some of the older chemotherapy we've got. So monoclonal antibodies are a major change in the last decade or two, particularly in GI and rheumatology and in oncology. The monoclonal antibodies have a certain nomenclature, and I'd encourage you to be familiar with this nomenclature. And the nomenclature is derived from the actual source of the monoclonal antibody. The least precise of the sources, the one that is most distant from our human antibodies, are those derived from mouse or murine. And you'll notice that within the monoclonal antibody generic name, you'll find 2 or 3 highlighted letters And for murine-derived or mouse-derived monoclonal antibodies, those are MO. The last three letters of all of these monoclonal antibodies are MAB, standing for monoclonal antibody. So the generic name of any monoclonal antibody will end in MAB, M-A-B, and then the source of that particular monoclonal antibody could be from a mouse, chimeric formulation, humanized formulation, or actual human, identical human antibodies, and monoclonal for one particular, targeting one particular protein. You'll find MO for murine-sourced, chimeric, XI, rituximab, for example, humanized, ZU, trastuzumab, and finally human, MU, panitumumab. So you'll find that as the monoclonal antibody is more human, there's less risk for hypersensitivity reactions. As it is more mouse-like, there are greater degrees of hypersensitivity reactions associated with that product. They work primarily by augmenting an existing immune response. They may flag cancer cells, or trigger cell membrane destruction. They could work to block cell growth or sort of interfere with a particular process. One common intervention in some types of cancers is to actually cut off the blood supply to that cancer. The benefit of that is that you reduce the blood flow to that highly vascularized tumor, for example. The downside is that it may not be specific for the blood flow to that tumor, and so those agents have to be used very carefully for someone, for example, who has existing coronary artery disease where they have reduced blood flow to their heart tissues as well. Other things we think about in oncology, specific blocking the immune system inhibitors. They can directly attack cancer cells. They can actually be tagged with a radioactive particle called radioimmunotherapy that the monoclonal antibody targets to that protein, and the radioactive isotope is attached to that monoclonal antibody to really target radiation. Same could be true for chemotherapy. We're not quite there commonly with delivering chemotherapy by monoclonal antibody yet, but likely to be there in the next decade or so. And combining cancer and immune cells, combining two monoclonal antibodies that attach to cancer cell, and that trigger then the immune system to attack that cancer cell. The most common of the, and really serious of the side effects of monoclonal antibodies are hypersensitivity reactions, which can range from relatively mild to full-blown anaphylaxis. And so we need to be careful about that. On infusion, it's typically common. Most of these monoclonal antibodies are given by infusion, IV infusion, usually in an infusion suite scheduled as a cycle or as every 4 weeks or every 6 weeks or every 8 weeks, depending on the regimen and the drug. And you'll find that during infusion, you could get a whole host of reactions. Typically what you'll see, though, is some type of anaphylactoid kind of reaction if it does happen. It can be mild, such as hives, urticaria, itching, that are IgE-mediated, or flu-like symptoms, fever, chills, muscle aches and pains, nausea, vomiting, skin rashes, and low blood pressure. All of those are likely, or we're most concerned about, IgE-mediated reactions. And depending on the severity of that reaction, we weigh the risk and the benefit of another dose after that reaction. Some of these monoclonal antibodies actually require us to pre-treat the patient with antihistamines, maybe with corticosteroids, or other agents to reduce the risk for an allergic reaction happening during infusion. So the common side effects and the serious side effects, the most common and serious are the anaphylactoid kind of reactions that we worry about. We could also see other serious reactions, rare but do happen: heart failure, bone marrow suppression, heart attack or MI, hypertension, or inflammatory processes like inflammatory pulmonary disease, or even on occasion. Lastly, let's briefly talk about gene therapy, which is not quite ready for prime time, but is certainly therapy that we have some in general medicine, some progress on. I think there is some, has been since the first thought of gene therapy, there are concerns for ethical, appropriate use of gene therapy. But gene therapy, basically, a technique that uses genes to actually treat or prevent a particular disease by replacing a mutated gene with a healthy copy of that gene. And so it has a great deal of promise. The way this gene, it's actually injected or inserted into the cell, often by a virus. And so we'll look at a adenovirus vector or a virus way to get the drug into the cell and then actually insert the new gene into the cell. So there's a lot to be said for this type of modality. It offers the potential for something close to quote-unquote cure, and we don't see cure for many diseases typically when we have pharmacotherapy. But of course, there are also some concerns for, ethical concerns for the role of gene therapy. So this last slide, I'd encourage you to sort of look through it, but some of the ethical questions are how, the same kind of questions I think that we talk about for genetically modified foods or other kind of genetic modifications. Is there something that could introduce some problem we don't envision that could really be devastating, potentially fatal, and not only to that individual, but could that be future transmitted to other individuals? And so there's lots of sort of questions about that, as well as the whole sense of changing the genetic makeup of a person. So lots to be thought about here.